Welcome to Pixel Notes. We present medical topics in a simple way.
Using a high-frequency linear probe, I am scanning the inner side of the right arm for identifying the basilic vein. By applying color Doppler, you can identify the brachial artery and the basilic vein. Once the basilic vein is identified, make sure that the lumen of the vein is large enough to accommodate the PICC line and that there are no thrombus formation or gross anatomical anomaly of the vein by scanning up and down and scanning in the longitudinal orientation. While inserting the introducer needle, the ultrasound scanning should be done in the longitudinal orientation along the long axis of the basilic vein so that the whole length of the needle is visible. Once a good flow of venous blood is drawn, the guide wire is inserted. The placement of the guide wire should be confirmed with ultrasound again. Now, the catheter can be inserted over the guide wire, while taking care not to bend the catheter along with the guide wire. After successful insertion of the catheter to the desired length, the guide wire can be removed. It is important to remember that the catheter may migrate to the neck vessels instead of going to the superior vena cava and the right atrium. So, before fixing the catheter, always check the location of the proximal end of the catheter by scanning the neck vessels and renegotiate if necessary. The ability to obtain venous access in the inpatient and outpatient setting is one of the most fundamental, yet crucial components for a large number of diagnostic and therapeutic interventions. It is especially vital for critically ill patients who often require frequent blood sampling. Vasoactive medications, rapid fluid resuscitation, prolonged antibiotic administration, and various other indications. Venous access can be obtained through conventional peripheral intravenous lines, midline peripheral catheters, and central venous catheters. Peripherally inserted central catheters are a subset of central venous catheters. They are 50 centimeters to 60 centimeters long single, double or triple lumen catheters that are placed in a peripheral arm vein and terminate in the thorax. They can be used for medium-term venous access, which is defined as anywhere between several weeks to 6 months. By definition, a central catheter is a venous access device that ultimately terminates in the superior vena cava or right atrium. They can be inserted centrally or peripherally. PICCs are placed through the basilic, brachial, cephalic, or medial cubital vein of the arm. The right basilic vein is the vein of choice due to its larger size and superficial location. Additionally, it has the straightest route to its destination, as it courses through the axillary vein, then through the subclavian, and finally settles in the SVC. Other factors that have been thought to make the basilic vein the superior choice for PICC lines are that it has the least number of valves, better hemodilution capabilities, and has a shallower angle of insertion compared to other veins. The median cubital vein usually offers the second best insertion site because it is prominent in the antecubital fossa and courses directly to the basilic vein and onward into the SVC. However, given its location in the antecubital fossa, constant bending at the elbow increase the risk of complications such as mechanical phlebitis. The brachial vein is another option due to its larger size. However, it is smaller and runs deeper than the basilic vein. It also courses close to the brachial artery and median nerve, and therefore, it usually requires ultrasound guidance for access. The PICC is a reliable and safe method for obtaining central venous access. They are indicated in patients who require venous access for several weeks to months due to their low infection rates. Additionally, they can be managed in inpatient and outpatient settings. Common indications include patients with limited peripheral access, long-term IV medication administration, continuous administration of vesicants or drugs that irritate peripheral veins, such as vasoactive drugs and chemotherapeutic agents, delivery of hyperosmolar solutions, or substances with extreme pH, such as total parenteral nutrition. Blood product infusions, frequent blood draws, patients with coagulation disorders, major anatomic abnormalities in the chest and neck that make central catheter placement difficult. Rapid infusions, there are essentially no absolute contraindications to central venous catheterization, especially in emergent cases when the above indications are necessary for life-saving interventions. There are, however, several relative contraindications for PICCs. These include burns, trauma, skin infections, radiation, history of venous thrombosis at insertion site, active bacteremia, Small diameter of arm veins, smaller than 3 mm to 4 mm. Prior mastectomy and lymph node dissection.
Now coming to the complications. Infection. As with any indwelling catheter in the body, there is always the risk of infection. This can result in cellulitis, abscesses, or bacteremia and systemic infections. The most common organisms associated with hospital-acquired CRBSIs are coagulase-negative staphylococci, Staphylococcus aureus, enterococci, and candida. Infection rates are higher for PICCs placed in the antecubital fossa compared to those placed in the upper arm like the basilic vein. Catheter malposition or migration. PICC malposition is common. They can be misplaced in the jugular vein, brachiocephalic vein, or azygos vein. Causes include vascular abnormalities, a patient's position during insertion, or changes in venous pressure inside the chest if a patient coughs or vomits. Mechanical malfunction. Another major complication is device malfunction, with anywhere between 10% and 27% of PICCs developing mechanical failure. Phlebitis or infiltration. Phlebitis and infiltration are complications that occur in 2.2% to 23% of patients with PICCs. It is a result of mechanical damage from the catheter itself or chemical irritation. Phlebitis may occur within the first week after insertion and can be treated using nonsteroidal anti-inflammatory agents or with the warm compress. Removal of the catheter is not necessary if chemical irritation causes it. Diluting medications or administering them at a lower rate can decrease inflammation. Air embolism. Air emboli are extremely uncommon with PICCs. However, they can occur. They are caused by an inability to maintain a closed system between the catheter and vasculature. Cardiac arrhythmias. Arrhythmias are caused by the catheter tip being positioned too low into the right atrium or ventricle due to primary or secondary malpositioning, resulting in conduction abnormalities. It can be easily corrected by withdrawing catheter to its correct position and securing it to prevent migration. Catheter occlusion. Catheter occlusion can occur as a result of thrombotic and non-thrombotic causes. A blood clot is the most common cause of catheter occlusions. Other causes of occlusion can be non-thrombotic. Malpositioning, such as catheter abutment against the wall of a vessel or kinking, can cause occlusion. Additionally, drug precipitation among incompatible medications. Solutions can block the catheter. Common drugs known to precipitate are etoposide, calcium diazepam, phenytoin, heparin, and total parenteral nutrition. PICCs have several advantages over other central catheters. They provide medium-term venous access for several weeks up to 6 months. They are much more easily accessible due to their peripheral exit site and are capable of delivering the same caustic medications and fluids at similar flow rates compared to other central catheters. They can be easily placed and removed at the bedside by nursing staff. PICCs can also be used in thrombocytopenic patients with platelet count less than 50,000 per mm. PICCs do have some limitations. However, they are usually smaller bore, which is less useful for frequent blood draws. Additionally, for patients requiring daily access for stem cell or blood product administration, surgically inserted central catheters are preferred. Finally, tunneled central catheters and implantable ports can be used for longer than 6 months, whereas PICCs are not indicated for that length of time, although they have been known to be functional for more than 300 days. In conclusion, PICCs are an excellent option for various diagnostic and therapeutic interventions and offer clinicians and nurses a safe and effective option for central access. They have been shown to be more cost-effective, have lower complication rates than CICCs, and continue to gain popularity in the intensive care setting. That is about peripherally inserted central lines. Thank you, good night, and good luck.